بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. I would like to welcome all the participants, and today we have two talks. The first, Professor Hatem El-Lawati is going to explain to us what are the pharmacology of radial during radial intervention. A lot of drugs are being used. There is a cocktail, there is spasmolytic drugs, there is a lot of drugs. He will explain it to us, and we can ask him questions later on. And the second lecture will be from Professor Mansour. He is going to discuss tips and tricks in Radial Course. So we will start puncturing the radial artery today with Mansour. May I invite Professor Hatem to start? Hatem, you are very welcome, and I'm very nice to have you and to meet you from now and then. You have actually enriched our course, and the people and myself are very happy to have you with us.
It is my pleasure, Professor Sameh, to be invited to this course and to participate actively in this course. I feel deeply honored and privileged. Assalamu alaikum, good evening everyone, and it's my pleasure to participate again in this course, and thanks are in order to the course director, Professor Mansour Salam, and the course chairman, Professor Sameh Alam. This time I was asked to talk about the pharmacology that we use on a day-to-day basis in the cath lab, and try and shed some light on some of the practical aspects for why we use certain drugs in the cath lab, and we'll try and make it pertinent to the radial interventionist. In specific, I was asked to talk about or try and address two specific questions. The first question I was asked to address is the use of vasodilators in the prevention of radial artery spasm. We've all had the fortune of working at multiple centers, at multiple institutions, and have been exposed to various practices. And I think it's time we took a step back to try and understand, is there any evidence to support this variation in the practice? Or is it all derived from personal experiences and personal preferences? Radial artery spasm is a vast topic. There is a lot to talk about, starting from pathophysiology to the pharmacology to prevent radial artery spasm and the drugs that can be used to treat radial artery spasm. And I'm going to try and focus my talk on what we do before we instrument the radial artery to try and prevent spasm, and try and show you some of the published evidence as well. The incidence of radial artery spasm is quite variable. The reported incidence varies in the literature depending on which group you read for and which paper you look at. As you can see in this tabulated summary I'm presenting in front of you, the rates have been reported anywhere from 2.7% up to 51.3%. The accepted incidence is somewhere around 30%. And if you think about it for a moment, that still is quite high in incidence. If you translate it into simple numbers, every third patient you catheterize from the radial artery ends up getting radial artery spasm. And the reason why the incidence, at least the reported incidence, is so variable is multifactorial. And I think one of the important reasons for this is the definition that the investigators use for radial artery spasm. A lot of the times they rely on subjective parameters like pain at the time of instrumentation of the radial artery or inability to manipulate catheters. Only very few studies actually go far enough to angiographically document radial artery spasm with a selective radial injection. Nevertheless, it is a huge problem. And I think we all agree that radial artery spasm is the rate-limiting step in determining the success of a radial intervention. You end up with bad spasm, the operator can end up crossing over to the contralateral arm or the femoral approach. So when the poor radial interventionalist is faced with spastic temperamental radial artery with all these predisposing factors, he has very little in terms of instruments or tools or weapons under his belt to try and overcome the problem, and a few choices of medications to try and tame a spastic radial artery, which can sometimes be harder than taming an angry medusa. These are some of the commonly used drugs that operators use to try and prevent radial artery spasm at the start of their radial instrumentation. So there's a lot of experience with verapamil, there is some experience with diltiazem, there's a lot of experience with organic nitrates, and there are anecdotal reports of the use of sodium nitroprusside, alpha adrenergic blockers, and molsidamine, selective vasodilators. There's a lot of literature published out there, and the most commonly quoted series of studies are the Spasm group of studies. So the first in the series of the Spasm studies was published in 2006, and the investigators looked at nearly 600 patients. Those patients were randomized to receiving nothing and undergoing a radial procedure versus molsidamine in 200 patients and verapamil, 5 milligrams given intra-arterial in another 200 patients. The incidence of radial artery spasm in those who did not receive any vasodilators was quite high, 22%. So every fifth patient ended up getting very bad radial artery spasm. And using molsidamine, which is a vasodilator that acts like organic nitrates, reduced that incidence by a significant margin, from 22% down to 15.3%, and the difference was statistically significant. When compared to verapamil, using verapamil at the 5 milligram dose resulted in further halving of the incidence of radial artery spasm, with a difference that was highly statistically significant. So it was clear from earlier studies that using vasodilators significantly reduced the risk of radial artery spasm. The Spasm 2 study was more of a dose finding study or a combination finding study, where operators tried to find the best dose of verapamil and the best combination to further minimize the risk of radial artery spasm. It was a smaller study which was interrupted because the outcomes were sort of not what the investigators expected. So at 2.5 milligrams of verapamil, the incidence of radial artery spasm was 8%, which is very comparable to the results that they reported in the first Spasm study. But paradoxically, when you gave 5 milligrams of verapamil intra-arterial, there was an increase in the incidence of radial artery spasm for reasons that the investigators could not understand or explain. And even when you combine verapamil with molsidamine, the incidence of radial artery spasm was still higher when compared to using verapamil at the dose of 2.5 milligrams only. Again, findings that were very hard to explain. The most recent in the series of Spasm studies compared diltiazem to isosorbide dinitrate intra-arterial to verapamil. And the results are shown in the table in front of you. There was a significant reduction in the risk of radial artery spasm with isosorbide dinitrate and with verapamil. And interestingly enough, the incidence of radial artery spasm was quite high in those who were treated with diltiazem at 26.6%. There are a lot of other studies similar to these. And for the sake of time and just to make life easy for our audience, I'd like to draw their attention to this systematic review, which summarizes all the studies and all the evidence that examine the use of vasodilator medications in preventing radial artery spasm in patients undergoing transradial catheterization. So the study compared various drugs to each other and various doses with one another and various combinations with one another. One thing that is clear is that the use of vasodilators is better than using no vasodilators, except for the first study, which we'll come to in a moment. Verapamil at 2.5 milligrams was better than placebo. It resulted in a significant 63% relative reduction in the risk of spasm. A smaller dose of verapamil combined with nitroglycerin resulted in an even further reduction in radial artery spasm. Combining verapamil with malcidamine was better than placebo. Giving malcidamine or nitroglycerin alone was better than placebo. The first study was an investigator-initiated randomized double-blind trial that compared 5 milligrams of intraarterial verapamil to placebo. And there were 600 patients, nearly 600 patients enrolled in the trial and randomized 1-to-1 to verapamil versus placebo. The primary endpoint was the rate of access site conversion, which was numerically higher in the placebo group, but the difference did not reach statistical significance. There were a number of secondary endpoints that were pre-specified and that ended up being similar in both treatment groups, except obviously for overall verapamil use, which was understandably higher in the verapamil treated group. The investigators concluded that the preventive use of verapamil may be unnecessary for transradial interventions, and that not only reduces the risk of complications from verapamil, but allows also the safe extension of transradial approach to those in whom verapamil is contraindicated. Say, for example, patients with severe valvular aortic stenosis or patients with acutely decompensated heart failure from severe LV systolic dysfunction. The results are a little counterintuitive when you compare it with the other studies. We still don't understand why 5 milligrams of verapamil in this particular study resulted in a negative result. Because if you look at the Spasm 1 trial, where they also used 5 milligrams of verapamil, there was a significant reduction in the risk of radial artery spasm with that dosing. When combining data from both studies, the end result is still a significant reduction in radial artery spasm. We're talking about a significant 62% nearly relative reduction in the risk of radial artery spasm with 5 milligrams of verapamil when compared to placebo. If you use 2.5 milligrams of verapamil, you still get a significant reduction. And when you combine verapamil with a vasodilator, you seem to get a better effect. So that's when you compare verapamil with placebo and you assess spasm by subjective measures, restricted movement or pain. When you compare calcium channel blockers with one another in terms of their efficacy in reducing radial artery spasm assessed by restricted movement or pain, it appears as though 2.5 milligrams of verapamil is no different than 5 milligrams of verapamil. And 2.5 milligrams of verapamil is no different than verapamil with a vasodilator. And the same thing is seen with 5 milligrams of verapamil compared to 2.5 with a vasodilator. The interesting thing is verapamil seems to result in a significant reduction in radial artery spasm when compared to diltiazem, albeit diltiazem is supposed to have more peripheral vasodilatory effect compared to verapamil. And again, something that Rossechner and his group could not explain. When comparing calcium channel blockers with other medications and combinations, and this time assessing spasm objectively with ultrasound or angiography, it appears as though verapamil 2 milligrams combined with nitroglycerin 200 milligrams was equivalent to Nicorandal. But the comparison may not be fair because the dose of verapamil used was rather unconventional. Verapamil at 1.25 milligrams with nitroglycerin versus nitroglycerin alone didn't seem to be any different. When you combine verapamil with nitroglycerin, it's obviously better than placebo, and we've seen this before. And the interesting thing here is this Brazilian group showed that diltiazem combined with isosorbide mononitrate was far superior to mononitrate alone. Now remember, there was an earlier study that used only 5 milligrams of diltiazem and showed an increase in the risk of spasm. That was the Spasm 3 study. This older study used a much bigger dose of diltiazem, 25 milligrams of diltiazem given with 1 milligram of isosorbide mononitrate as a slow infusion, intraarterial, as soon as you put the sheath in. And what they've noticed was a significant increase in the diameter of the radial artery from before the procedure to 30 minutes after the procedure, assessed by ultrasound, and a significant increase in radial artery output assessed by peak systolic velocities using Doppler interrogation of the flow in the radial artery from before the procedure to 30 minutes after. So the fact that diltiazem resulted in increased risk of spasm might have been just the dose effect, and perhaps higher doses of diltiazem might have tipped the balance in favor of diltiazem compared to verapamil and molsidamine. Again, when you compare calcium channel blockers to other vasodilator medications with spasm being assessed by restricted movement and pain, there didn't seem to be a big difference between verapamil, molsidamine, whether it's the 2.5 milligram dose or the 5 milligram dose, but when you combine the two, you get a better effect than using a vasodilator alone. And I think this has been the practice in most places. You combine, or at least the places where I practiced, you combine verapamil with a vasodilator, most commonly nitroglycerin. There are anecdotal reports of novel vasodilators like magnesium sulfate, and this didn't seem to be any further superior to verapamil. However, the comparison may not be fair because they only used 1 milligrams of verapamil in the study. Verapamil seemed to be superior to phentolamine, which is a selective alpha-adrenergic blocker. Verapamil at 2.5 milligrams resulted in a similar reduction in the rates of radial artery spasm compared to isosorbide dinitrate. And nitrates were superior to diltiazem at the dose of 5 milligrams. And this we've already seen in the Spasm 3 study. In fact, the Spasm 3 study has identified the use of diltiazem as an independent predictor of the increase in the risk of radial artery spasm in comparison to the other risk factors like male gender, the emergent nature of the procedure, and multiple attempts at puncturing the radial artery. But at higher doses, like we've seen in the Brazilian study, it appears that diltiazem does cause favorable vasodilatory effect. But again, a big question mark on how many patients would tolerate such a big dose of diltiazem given intraarterially. We've already established that vasodilators are better than placebo, but when you compare the various combinations of nitrates, there doesn't appear to be a big difference. So nitroglycerin 100 micrograms with nitroprusside 100 micrograms, no difference. Again, a big question mark whether bigger doses of nitroprusside would have resulted in more vasodilatation, knowing that it's a selective arteriolar vasodilator and a much more potent one than nitrates. Combination of nitroglycerin with nitroprusside was no superior to nitroglycerin alone, and nitroglycerin with nitroprusside was no superior to nitroprusside alone. Molsidamine was superior to placebo. And then we have another novel vasodilator which was studied, Nicorandal. Now, Nicorandal is unique in that its pharmacokinetic properties depend on its plasma levels. So at low plasma levels, it has vasodilatory properties similar to those of organic nitrates, nitroglycerin and isosorbide mononitrate. And at higher plasma concentrations, it actually inhibits the ATP potassium channels, and the hyperpolarization that results from blocking those channels inhibits the voltage-gated calcium channels, resulting in smooth muscle relaxation. And investigators in this study compared Nicorandal at 4 milligram dose to the standard combination, which is used in a lot of cath labs, 200 micrograms of nitroglycerin with a rather small dose of verapamil, 100 micrograms. And they showed that Nicorandal actually resulted in a greater mean difference. And by difference, I mean mean increase in radial artery diameter compared to the standard combination of verapamil nitroglycerin, whether it was in a proximal segment in the radial artery or a distal segment closer to the insertion site. However, there was no difference in the risk of spasm between the two groups. Radial artery spasm was seen in 50% of patients in the Nicorandal treated group in that study, and 52% of patients treated with a standard cocktail. There was no difference in the incidence of spasm and the distribution of spasm severity, and the rates of crossover to the femoral approach were comparable in both groups. So again, it didn't seem to be any superior to the standard combination. So as you can see, the evidence to guide us on the best drug, the best dose, the best combination of agents for the prevention of radial artery spasm is quite confusing. And I think you can understand why. Because the dosing is never consistent. The agents that are used are never consistent. The numbers of patients that are enrolled in the studies are relatively small. For us to be able to draw firm conclusions on which is the best combination, which is the best drug, or which is the best dosing regimen, you need to have consistency in dosing. As you can see, some of the studies used verapamil at 1 milligram dose. Some of them used it at 2.5, 5 milligrams, and so on and so forth. But the common practice is, at least in the centers where I worked and my present center, is 2.5 milligrams of verapamil combined with 100 micrograms of nitroglycerin, and that seems to work most of the time. It doesn't completely eliminate the problem with radial artery spasm, but it makes it more manageable. I wonder if this still is your practice, Prof. Mansour?
Dr. Hatem?
Yes, Prof. Mansour.
Okay, please. Could you please repeat your question?
So my question was that as far as your practice is concerned presently, do you still use the combination of verapamil nitroglycerin, or have you given up on verapamil altogether, or do you use any other combination?
Yes. I think traditionally we are using 100 microgram nitroglycerin combined with verapamil 2.5. This is the traditional regimen for our elective patients. However, there are restrictions or limitations for in many situations, like in hypotension, bradycardia, even in all patients with STEMI, either inferior or anterior STEMI. Inferior STEMI because I don't expect any conduction disturbances, so I don't use verapamil at all. Even if the heart rate is fine, even if blood pressure is fine. And even with anterior segment elevation myocardial infarction, I do expect a larger area of infarction, so I don't also give verapamil scared from any stunned myocardium and further hypotension.
Yeah. And I think by the same token, you would be concerned about somebody coming in with an inferior STEMI with an RV extension, and whether you should be giving them any nitrates at all, knowing that the hemodynamics are very preload dependent. I wonder if Prof. Sameh also shares these concerns when he uses his vasodilator cocktail.
Definitely, in patients with inferior myocardial infarction, if we suspect right ventricular infarction, definitely any dose of nitrates or vasodilators will decrease the preload and will cause deteriorate hemodynamic effects and severe hypertension and sometimes shock. It happened even with sublingual nitrates, not intravenous nitrates.
Exactly, you're right. I remember one patient, Dr. Hatem, Dr. Sameh, who presented with inferior segment elevation myocardial infarction with blood pressure 240 over 130. Can you imagine? 240, yes, it's okay, it's expected. I just opened the RCA with the small balloon, it was totally occluded, and I gave just 100 micrograms nitroglycerin intracoronary. 140. Okay. Blood pressure dropped immediately from 140 to 130. Okay, to 130 over 70 millimeter. Okay, this is what's called due to basal-gyrus reflex. Okay, I think what's beyond our scope right now. So dramatic blood pressure drop like that, I think it may put us in a problem. Suppose this patient presented with blood pressure 130. So what do you expect about this 100 mic nitroglycerin? So usually we do prefer to avoid such medications in inferior segment elevation myocardial infarction.
Okay, let us summarize for the audience. In all patients with inferior myocardial infarction, look at right ventricular involvement. And in such a case, do your best to avoid nitrates and the vasodilators. Otherwise, the patient will go into the shock. This is to conclude for the audience. Okay, carry on, Dr.
Thank you, Prof. Mansour and Prof. Sameh. So to summarize the first part of my presentation, the data on the use of vasodilators in prevention of radial artery spasm is rather inhomogeneous. The information that we can take home that there's a lot of experience with verapamil at various doses. The 2.5 milligram appears to be the so-called sweet spot when it comes to verapamil, and it appears that the verapamil nitroglycerin combination is also a popular choice in prevention of radial artery spasm, and the combination with the most experience. Other drugs have been tried, whether they're more effective or not. The studies that looked at them are small, and therefore one cannot draw firm conclusions from those studies, and bigger studies are required in a more systematic fashion to answer those questions. So that sums the first part of my presentation. The second pharmacology-related question I was asked to answer is, so you have a patient who comes in with an acute coronary syndrome who needs to go to the cardiac catheterization laboratory for an urgent coronary angiogram. But the patient, for some reason, is on an anticoagulant, whether he has atrial fibrillation, had a stroke in the past, or has a mechanical valve, or has an LV thrombus from a previous event. So how do we manage the situation? Do we stop the anticoagulant and bridge him with something that's short-acting in preparation for his upcoming procedure? Do we proceed? Do we reverse anticoagulation and then top him up with some heparin in the lab? Do we wait and bridge as long as the procedure is not urgent? What if it's a STEMI? What do you do then? So I think we're all encountering an increasing number of patients in this category because of the increasing incidence of atrial fibrillation and patients who come to us with mechanical valves who are anticoagulated, who come in 10 years down the line with their first acute coronary syndrome. And to make things a bit more complicated, we have this group of direct oral anticoagulant drugs, which are not so straightforward to monitor. Big question marks have risen on how you manage anticoagulation in the cath lab when your patient is on rivaroxaban or dabigatran for that matter. So I think this study sorts out the concern about whether these patients should be put on a corner with their anticoagulant of the anticoagulant they're on withheld and bridged until their coronary angiogram. This was the management of patients with AFib undergoing coronary artery stenting study, which compared two groups of patients who had AFib on vitamin K antagonists who actually went on to have the coronary procedure and coronary stenting on vitamin K antagonists without reversing, without stopping, without discontinuing, and without bridging. And this was compared to a group of patients in whom the vitamin K antagonist was discontinued. The patients were put on low molecular weight heparin bridge anticoagulation until their procedure, and then bridged again after their procedure until they became therapeutic on warfarin. And as you can see, when you look at bleeding events, there was a significant increase in the risk of bleeding events in low molecular weight heparin treated group, in the bridged group. And this is expressed as freedom from major bleeding, which was significantly lower in the bridged group. Now, if you look at the two curves, you notice that they diverge fairly early during the course of the follow-up. And we're looking at the first 3 months after PCI. So very early on, as early as the first few days after PCI, you begin to notice a significant increase in bleeding events in patients who were bridged with low molecular weight heparin. We're talking about a hazard ratio of 3.51. So a 3.5-fold increase in the risk of bleeding complications in the first 3 months from the PCI procedure. And the major bleeding events continued to happen throughout the course of the ensuing 9 months. So at 12 months, the hazard ratio was still 2.2 with a significant difference between the two groups. Not only that, but there was a significant increase, there was a significant increase in the risk of major adverse cardiovascular events in the bridged group. Again, the difference was seen very early on after PCI and continued up to 12 months after PCI. We're talking about a 2.7-fold increase in the risk of major adverse cardiovascular events in the patients who were treated with low molecular weight heparin or who were bridged with low molecular weight heparin. And this was the first study that raised big question marks as to whether we should just let these patients proceed to PCI while they're on vitamin K antagonists without stopping, interrupting the treatment and bridging them with low molecular weight heparin. Concomitant with that study was a subgroup analysis published from the Woes Trial. Now, to remind our audience, the Woes Trial was a trial that looked at the safety of single antiplatelet therapy with vitamin K antagonists in patients undergoing PCI compared to triple therapy, aspirin, clopidogrel, and vitamin K antagonists. And they looked at bleeding complications and major adverse cardiovascular events, particularly death and stent thrombosis, for a 12-month follow-up period after the PCI procedure. And it turns out that using a single antiplatelet agent, often clopidogrel with vitamin K antagonist, resulted in a significant reduction in bleeding complications without a significant increase in stent thrombosis. And following this, there were a number of other trials which established the safety of single antiplatelet therapy with anticoagulation. So there was a subgroup analysis from that trial which tried to address that same question, whether uninterrupted oral anticoagulation was an acceptable strategy in patients undergoing PCI, or whether you had to actually stop vitamin K antagonists, bridge your patients with low molecular weight heparin or unfractionated heparin until such time that they're ready for their PCI. The Woes trial included patients with stable coronary artery disease, but a third of the patients in both arms, the bridging therapy arm and the peri-procedural anticoagulation arm, were admitted with acute coronary syndromes, and it underwent coronary angiography and PCI for acute coronary syndromes. The vast majority of patients had their procedures done from the femoral approach. And as you can see, the INR in the uninterrupted group was 2.5, and in the bridging group was 1.48 at the time of their procedure. The management of anticoagulation intra-procedure was left to the discretion of the operator. So very few patients received no additional anticoagulation, right? Almost everybody received extra anticoagulation during the procedure. About half of the patients received more than 5,000 units and half of the patients received under 5,000 units. And the outcomes were very similar. There was actually not similar. It's similar in the sense that peri-procedural oral anticoagulation did not result in increase in major adverse cardiovascular events, specifically death, MI, stroke, target vessel revascularization, and stent thrombosis. So the difference between the two groups was not statistically significant, and we're looking at 30 days, we're looking at 180 days, and we're looking at 1 year. And when you're looking at bleeding events, there was a slight increase, numerical, in the bleeding events, but the difference was not statistically significant. Again, consistent with the results of the earlier study. So radial operators started becoming more comfortable doing radial interventions with patients fully anticoagulated with vitamin K antagonists without having to stop warfarin or Coumadin for that matter. But then, does the same apply to direct oral anticoagulants or the novel oral anticoagulants? Is the situation the same with them? Can we do procedures on the novel oral anticoagulants like it has been proven to be safe with vitamin K antagonists? This is a very eloquent study that was done in animals by Yao and his team. And they basically tried to look at the occlusion time through a catheter that was inserted in the jugular vein of rapids. So basically what they did was they aspirated blood from the central line, and then they injected it back, and they kept doing it until there was no flow coming back from the catheter. And that suggested that the central venous catheter was thrombosed. And then they put patients on 3 dosing regimens of dabigatran, starting with 75 milligrams BD, 110 BD, 150 BD, and compared it to 70 units per kilogram of heparin. And it turns out that those who were on dabigatran thrombosed their catheters much earlier and significantly so compared to those who were treated with unfractionated heparin. And the interesting thing is when you look at the study that was done in humans, even though you're using the standard guideline accepted doses of dabigatran at 110 BD and 150 BD, if you look at the coagulation parameters, you notice that there's no change in the APTT as expected with dabigatran, but the APTT increases when you treat with heparin. That's kind of expected. If you look at D-dimer levels, you notice that the D-dimer levels are sort of all over the place, but there is a surge in D-dimer levels with the 150 milligram BD, suggesting that there is some clot dissolution that is happening. When you look at the prothrombin fragments, the boxed line here is heparin. It appears to be well suppressed for the first couple of hours after a bolus of heparin, the 70 units per kilogram, but there is ongoing formation of prothrombin fragments with dabigatran at all dosing regimens. And if you look at the thrombin-antithrombin complex, you effectively inhibit the levels of thrombin and antithrombin complex with heparin, but the levels continue to be detectable and actually quite high with dabigatran at all doses. So that suggests that dabigatran is not as effective at inhibiting thrombus formation compared to unfractionated heparin. And this actually, in this particular study, translated into worse clinical outcomes. And this was seen in the form of an increase in the need for bailout anticoagulation due to catheter-related thrombosis during the procedure in the patients who were treated with dabigatran compared to those who were treated with heparin. Abrupt vessel closure, myocardial infarctions, periprocedurally were seen more frequently with the dabigatran treated group compared to unfractionated heparin group. So that raised big question marks on the safety of using dabigatran as the sole anticoagulant drug to support your antithrombotic therapy for patients going to the cath lab urgently and undergoing coronary procedures. So that's as far as the oral direct thrombin inhibitors are concerned. Does the same apply to the factor Xa inhibitors, so the rivaroxaban, apixaban, and edoxaban? I couldn't find much evidence on apixaban and edoxaban, but this Explorer randomized open label trial was done on patients who were treated with rivaroxaban, mostly for atrial fibrillation, and who had stable coronary artery disease, and patients who had relatively simple lesions. And they compared the levels of the coagulation parameters that I'm showing you in the next few slides, comparing 4 dosing regimens: rivaroxaban 20, rivaroxaban 10, rivaroxaban 10 milligrams with unfractionated heparin, and unfractionated heparin alone. And interestingly enough, unlike the trend you saw with dabigatran, rivaroxaban appeared to effectively inhibit thrombin-antithrombin complex, the fragment 1 and 2 levels, and the other coagulation parameters, as you can see, were very comparable to unfractionated heparin. And when looking at clinical outcomes, albeit the study was small and likely underpowered to detect clinical endpoints and angiographic endpoints, but there was no difference in myocardial infarctions periprocedurally between the rivaroxaban treated group and the heparin treated group. There was hardly any need for additional anticoagulation for bailout indications, and there was no increase in the risk of bleeding. a very interesting observation, a hypothesis-generating observation, highlighting the need for a bigger study to confirm these findings in a more systematic fashion. But until that data becomes available, what do we do with these patients? Because we're facing them day in and day out. The European Society of Cardiology released 3 documents, and all 3 documents share the same recommendations, starting with the document on the management of antithrombotic therapy in AFib patients presenting with ACS and undergoing PCI in 2014, to the most recent 2020 guidelines on the management of ACS without persistent ST segment elevation and their Q&A document. So this is derived specifically to answer those 2 questions we have in mind from the Q&A document. So the guidelines now recommend that during PCI, additional parenteral anticoagulation is recommended, irrespective of the timing of the last dose of all direct oral anticoagulants. And if your patient is on vitamin K antagonist, then additional parenteral anticoagulation is recommended if the INR was less than 2.5. If it's 2.5 or more, you don't need to supplement additional heparin to support your procedure. It's a class 1 recommendation, right? But it's based on consensus, expert consensus opinion, right? So again, highlighting the fact that there are no randomized controlled trials to address this very vital question. So if you have a patient with AFib and has a mechanical prosthetic heart valve who is on vitamin K antagonist, who is admitted with a non-ST elevation MI, and your interventional cardiologist wants to take him to the cath lab, how do you manage anticoagulation? The answer is very clearly stated. You can perform the procedure without interrupting vitamin K antagonist therapy, without stopping the warfarin or stopping the Coumadin. Radial approach should be your default vascular access site. If you're doing the PCI and your INR is less than 2.5, you have the option of giving unfractionated heparin to top up your antithrombotic therapy during the procedure, and the dose recommendation is given, and it's a class 1 recommendation. Or you use enoxaparin 0.5 milligram per kilogram that carries a class 2A recommendation. So very clear. What if your patient is on a direct oral anticoagulant or a NOAC, whether it's a direct thrombin inhibitor or a factor Xa inhibitor? Again, very clearly stated, you always supplement with additional parenteral anticoagulation, whether it's unfractionated heparin or enoxaparin, regardless of the timing of the last NOAC administration. So I think these recommendations are fairly easy to follow and very practical until more data is available from larger scale studies. And with that, I hope I answered the 2 questions that Prof. Mansour asked me to look into for our audience. Thank you.
Thanks very much, Hatem, for this very nice talk and a wealth of information about pharmacology and in radial artery approach and in cardiology practice in general, actually. Thanks very much, Hatem. It was very interesting. And what happened?
I am sharing my screen.
Okay. Mansour, you are invited to start your talk right now.
Okay. Do you see my screen?
Yes, we could see full screen. Yes.
Okay. بسم الله الرحمن الرحيم. قل إن صلاتي ونسكي ومحياي ومماتي لرب العالمين. I would like to welcome you all for the Radial Course, and I would like to thank my dear colleague, Dr. Hatem, for his elegant presentation that made my presentation a bit easier. Today, our theme of tonight, how to start a successful Trans-Radial program. And the main objective from this presentation is to make the complicated simple and the simple elegant. So how to start a successful Trans-Radial program? Even if you are senior, I think you will get benefit also from this program that may enrich your information. Based on my knowledge, so I can say the successful Trans-Radial program relies on 3 pillars or 3 milestones. First one is the cath lab setup, your preparation of your patient, proper preparation of your patient. And the third one is relies upon you, how it comes. So just let me discuss the first issue is the cath lab setup. Nurses and techs are integral part of the cath lab. All of us are complementary together. Just I would like, and I think Dr. Samah will agree with me, approximately 3 decades ago, when we started the cath lab, when they started the cath lab, there were just simple procedures like simple diagnostic coronary angiography, congenital heart disease, right side heart catheterization. Today is what we are doing. We are doing complex transcutaneous procedures, electrophysiology, congenital heart disease, structural heart disease, so many. So do you expect your nurses and techs will be familiar with all these procedures? The answer, definitely not. So I think that we have to teach them how to prepare the patients, how to prepare the paper, the table. Cath lab table is a little bit different from the usual one for the radial approach. So how to do and how to prepare, just we'll check right now. Also, you have to put in your mind the cath lab a little bit different for radial procedures with a dedicated catheters and sheaths as well. I think it requires a separate session to understand and how to prepare your cath lab. The slide arm board along with the cath lab extension table provide more surface area to work during radial procedure. Very, very important issue just we have to address. You have to put in your mind, we have a dedicated radial sheath and you have to have everything ready with a needed 21 gauge, hydrophilic sheath, silicone coated, and wire. I think the dedicated wire will come to. Dedicated radial sheaths, cylinder sheaths, dedicated radial catheters will be, inshallah, and will be discussed in a separate session will be given by our colleague, Dr. Abdul Masoud, inshallah, in next sessions. So the second pillar or second milestone to have a successful Trans-Radial procedure is your patient, proper preparation of your patient. So first of all, you have to know the contraindication to proceed for the radial approach. One of the most important of them is having arteriovenous fistula for a hemodialysis or a plan to get a hemodialysis arteriovenous fistula. If the patient refuses from bad experience or whatever, so I think you shouldn't start. Any bone deformities, upper extremity lymphedema, and radial artery occlusion from previous study, I think also it is a contraindication to proceed. You have to avoid at the beginning of your study or your course, at the beginning of your experience, you have to avoid morbidly obese patients. You have to avoid elderly patients because of many subclavian tortuosis that we discussed earlier. Peripheral arterial disease also will be associated with extensive coronary artery disease or extensive vascular disease along the course of the radial artery. You have to avoid at the beginning the complex BCI. Proper preparation of your patient is very, very important to prepare your patient. You have to educate and sedate to alleviate spasm. You have to physically and properly examine your patient, feeling the radial, ulnar, and femoral pulse, and you have to report all of these. You have to ask your patient to shave his or her groin for possible crossover to the groin. And you have to insert intravenous cannula in the contralateral side. Usually we do advise our nurses to insert intravenous cannula just at the upper forearm because sometimes we cross over to the contralateral side as well. There is no need right now to perform Allen's test because of the extensive collateral circulation in the hand, as we mentioned in the previous sessions. There is no need for the Allen test as proposed by the Radar study proposed by Dr. Samir Panshuri. So the third pillar for a successful program relies upon you as interventional cardiologist willing to shift from the femoral to radial. So I think there are many issues you have to address after proper preparation of your cath lab and after identification of the right patient and the preparation as well. You have to be enthusiastic, you have to be eager, you have to be insistent to start your program. you have to learn the facts, and I collected 12 proofs. Tonight, inshallah, we'll discuss choosing of the access method. You have to choose your proper catheter, which is a little bit different from the femoral access. And you inserted the sheath, so you have to know how to perform patent hemostasis to prevent radial artery occlusion. All this will be discussed. Just this is my experience right now. Okay, challenge to reduce crossover from radial to femoral. My practice still right now is rural. This stands for right radial. When I fail to get the right radial, irrespective of the cause, which is confined to the radial artery itself, usually I shift to the ipsilateral ulnar, right ulnar. Then, if I failed, I will go to the left radial, then left ulnar. This is my approach, which I am going to a little bit change right now, because I will go to the left radial, but I think it is another issue. I prepared for you 12 facts with their proof. I think before I start the radial program, you have to put in your mind. Okay, I will start with the transfemoral approach. Transfemoral approach, I think it is not, you have to know, it is not a competitor to the radial, but it is complementary. And I think it is should be your friend. And you have to be experienced in transfemoral approach when you start the radial approach as well. I think it was a very, very nice to start our program or our webinars with the full illustration of the trans-radial axis vascular anatomy, starting from the digital arteries until the coronaries. All this, I think, will be associated with increasing success, reducing the crossover rate, and recognition and managing complications. So I think when you drive your car, you have to know your map. Otherwise, you will not reach your destination, or you will reach with insult. The third fact that you have to know, okay, radial is different, even if you are experienced operator in the femoral approach, different in size, different in spasm, as my colleague Dr. Hatem right now mentioned clearly. Different in a radial artery occlusion. Despite all the proper precautions that we are taking, radial artery occlusion is still the Achilles heel of the radial approach. And with the best hands, it reached approximately less than 4%, which is quite high percentage as well. You have to know that radial is different from the femoral. We immediately remove the sheath, irrespective of procedure that you did. You have to know that you have to be familiar with the non-traditional catheter-like femoral approach. The size of the radial artery, just I would like to remind you, which ranges from 1.6 to 3.8 with average 2.6, which is a bit small. Even if you use the 6 French or 5 French catheter, you will be very close to the intima that may induce spasm, dissection, perforation, and finally radial artery occlusion, and finally you will cross over as compared to the femoral artery, which is approximately 9 millimeter in cross-sectional area, and your sheath is away from the wall of the artery. The fourth fact that you have to know that, and you have to be insistent about that, radial is safer as compared to the femoral approach. Fortunately, she is not my patient. I don't know her fate after this devastating perforation or complication or hemorrhage or hematoma. This is my patient. I know her very, very well. And this after devastating as well perforation resulting in massive hematoma. This is the same patient 4 weeks later. She fully recovered. During that time, the patient was completely ambulant and was doing her life as usual. So definitely it is safer, and because of mainly because of lack of less bleeding associated with radial approach. And does bleeding kill? The answer is yes. So I think radial is safer, and you have to insist for that. You have to know that radial is as effective as transfemoral approach. Based on meta-analysis of approximately 24 studies, included 23,000 patients, radial approach was as effective as transfemoral approach and was more safer as compared to it. This is the fifth fact. Fact number 6 is radial is better associated with better patient satisfaction and quality of life. And this mainly driven because of the early ambulation of your patient. And because of this early ambulation, the cost is less as compared to the femoral approach. And I think during the COVID pandemic, I think the early discharge is mandatory to avoid further infections. The eighth effect is there is a learning curve. And usually expert femoralists, they acquire the competency level very, very fast, this one. And with this, based on the European Society of Cardiology guidelines, you can perform as a single operator after 50 procedure trans-radial approach as a single. And you can, after 100 patients, you can manage simple PCI. But please, to start the program for the acute coronary syndrome, you have to perform approximately 400 patients. The ninth effect that expert radialists may suffer. Just to look for this patient who is approximately 170 kilograms. This patient is associated with 360 loop, and the radial artery originates high takeoff, was associated with intense radial artery spasm. We could overcome all these issues and to reach the coronaries. But what happened later? Just look for this video.
Okay, I'm doing my best right now, okay, to withdraw the catheter. Bismillah ar-Rahman ar-Rahim. Okay, هنا احمد شوية وهنا السكرين والتايمر. ما اجيبش وش المرض معلش. معلش يا عم تحمل يا عم. لو النبي. حاضر يا عم. والنبي. حاضر معلش.
Extremely sorry for this offensive video, but I think this is our real life. Okay, after doing our best, I think we have a lot of issues that you have to learn how to deal. Ultrasound guidance is very, very important right now, and I think it will be the routine practice in the next years. And the ultrasound guidance is associated with much less or significant less number of attempts. And one Dr. Hatim or expert radialist may claim that, no, I can't get it without ultrasound guidance, but I promise. The ultrasound guidance is very, very important, not only to get the number of attempts, but just look for this video or this real patient. I tried this patient to get many times, but the radial artery itself is very, very small, hypoplastic. How can you get it? Neither me or whatever the best word in the world, I think, cannot get. So ultrasound in such situation may help us to change our management plan. Look for this patient as well. Okay, I remember this patient very, very well. I punctured this patient 3 times. 3 times failed to get the proper radial artery. So I crossed over to the ipsilateral ulnar artery as my practice. And I found here the radial artery as a variant has terminated very, very early into 3 terminal branches. Each time I got the artery, but definitely the wire or the sheath can be inserted in such a situation. So I think ultrasound guidance is very, very important. Ultrasound guidance also can tell us about the high takeoff with intense spasm. We can avoid it, either left radial or whatever. Can also tell us about the radial loops and to make our life much easier. So ultrasound guidance, I think, for the radialist, I think it will be an integral part in any cath lab. The radialist, before we start soon right now, the pitfalls of the radial artery that you have to know. It requires steep learning curve. Prolonged procedure time and radiation, however, it reduced after getting experience. Radial artery occlusion is still, by best hands, 4%. Relatively small caliber that we cannot accommodate. For example, if you need French catheter for complex procedures, bifurcation or rotablation or whatever, and some patients still having some neuropathy with no explanation for that. The last but not least, to upgrade yourself, I think research work is very, very important, and you have to attend the clinical cases. You have to read and you have to attend the courses as well that we are doing. And if there is simulator, I think it will be very, very nice, and you have to do research work. Research work to advance your knowledge is very, very important. So shall we start right now? The trans-radial approach technical tips and tricks. Before we start, please, I summarized 16 points of resistance that you may get before we start radial approach. And the forearm that we'll concentrate today, you may not be enabled to puncture the radial artery. You have to expect spasm, loop, tortuosities, cannulation. In the arm, stenosis of the brachial artery, spasm or tortuosity. In the subclavian area, you may experience or expect any tortuosity or loops of the subclavian artery. Arterial isuria, subclavian artery stenosis. And I think in the aortic area, you may expect many morphological changes in the aortic arch that may be obstacle or block your advancement of your wire. Abnormal arch, vessel pattern, right side aortic arch, horizontal aorta, abnormal coronary artery. I think in the previous sessions, we have discussed all these issues. And tonight we'll concentrate on how can you get the radial artery puncture. And next week, inshallah, it will be very, very interesting topic about the radial artery spasm, the coronary artery spasm, and their relationship, how to prevent, how to predict, and how to treat. It will be interesting topic. Okay, so I think medications, Dr. Hatem, I think made my presentation very, very nice about the vasodilators and about heparin and whatever, so I will skip this one. And please, if you are working in the cath lab, not busy cath lab, so I think you have to have this checklist. If you are working in the very busy cath lab, so I think it is a must. You have to this checklist. I propose this checklist. Okay, just we can add or whatever, we can upgrade whatever, but I think these are the basic requirements to know about your patient. Before the procedure, you have to consent and you have to take jewelry for the females. You have to ask your patient about previous procedures and any allergy. Many patients, to be frank with you, and I have seen and I have practiced, okay, the lady comes with menstruation elective procedure, so I think can be postponed. Intravenous cannula should be inserted in the contralateral side. You have to tell us, or you have to know about loading, INR, platelet, hemoglobin, and please, you have to check the investigations of your patient. Before you skin incision, you have to be sure this is the same patient, not other patient. Your equipment's already, access site has been chosen, and your crash trolley is ready, contrast media type, and please concentrate about, you have to check about presence or absence of covered stent. After your patient leaves the cath lab, you have to report any complication, whether he's conscious or any complication happened, what is the procedure done, she's removed or not, how much contrast media, how much radiation time, and does your patient require any further monitoring or not. So the structured approach to get the radial artery includes, we have to prepare the right groin for any emergency situation, please, or expected crossover. You have to decide from the beginning, right or left radial, and I think it will be a separate topic versus right versus left radial, and you have to determine from the beginning whether you are going for anterior puncture or counter puncture. Okay, so step by step, 3 steps to start. Immobilize the hand of your patient. You have to give local anesthesia and puncture equipment and techniques that we will discuss right now. So immobilization of your patient is very, very important to avoid rolling of the radial artery to get it or to puncture it. The hand of your patient should be extended to bring the radial artery shallower for better puncture. And you have the rest of your patient should be put at rest for comfort of the patient. Second part is to give local anesthesia. How to give the technique, palpate the artery, and draw a measure line along it.
First step of getting radial approach is...
Extremely sorry, Dr. Samah, Dr. Hatem, do you hear the video clip well or not?
Yes, we do hear.
One of the most important tricks is to palpate the styloid process. Okay, styloid process. You will feel here the radial artery more pulsatile. And this is the commonest mistake to use in intervention cardiology. To get the radial approach is to puncture at the site of the styloid process. The proper site is 1 to 2 centimeters away from the styloid process. Why? I think we'll explain in different pictures after that and different angles. Usually the radial artery bifurcates 4 millimeters away from the crease. Approximately 4 millimeters. So usually it may bifurcate here. Bifurcate, you will get the superficial palmar artery with small artery and the spastic artery, and usually results in failure. So I will give local anesthesia. Bismillah ar-Rahman
Why are
ar-Rahim.
you using the needle, Mansoor?
Local anesthesia across the...
Dr. Samah?
Pointing by the needle, why?
Pointing? Okay, just for demo.
artery.
Okay.
ترفع تركيزها شوي احمد. While giving...
What you want, Dr. Samah?
Okay, no, carry on. Sorry.
first step of usually the radial approximately 4 millimeters. So bifurcate, you will usually and spastic artery, and usually results in local anesthesia across the artery. ممكن ترفع الترابيزه شويه يا احمد؟ While giving local anesthesia, try to distribute. Don't inject more contrast, and try to distribute the contrast across the artery itself.
So I am giving local anesthesia starting from the styloid process, despite I will not puncture the styloid process as I mentioned right now. I palpate the artery approximately 3 centimeters from the radial artery in measuring line, and I inject a small amount of contrast, of the xylocaine mixed with the nitroglycerin. Why that 3 centimeter? Because I do expect in many situations the focal spasm, and sometimes I go after that more proximal to be ready.
بسم الله الرحمن الرحيم. في أي علامة ثاني؟ بسيط خالص.
Okay. So the tips for local anesthesia: clean the forearm very well, just to avoid any betadine inside the sheath or the artery. Use insulin syringe as I use right now, 25 gauge for better comfort of the patient. Mix the lidocaine with the nitroglycerin for radial artery dilatation. Distribute it well. And usually I do anesthesia 2 to 3 centimeters alongside the radial artery. So the second step after local anesthesia to puncture equipment and the techniques. Okay, these are the dedicated sheaths and dedicated sheaths for the radial artery. And I am again and again and again, because it is a common mistake to use or to puncture the radial artery at the styloid process. When proposed by Campo in 1989, first time, he proposed that we have to get the puncture at the most superficial area or palpating area superficial. But I think after getting experience and right now we know why we shouldn't puncture here, I will tell you right now. I think we highlighted in details the normal artery and normal radial artery anatomy, and we clearly mentioned that it terminates approximately 4 millimeters away from the crease. It terminates into 2 branches, the deep palmar branch and superficial palmar branch. Superficial palmar branch is usually small artery that may bifurcate at the styloid process, and usually you get it, and be sure you will fail to get it. Spastic artery, very small artery, it will occlude and you will make a trouble from the beginning. So puncture 1 to 2 centimeter proximal to the radial styloid and start 1 centimeter, because anticipate focal spasm. If no focal spasm, I think you can, no problem. We have 2 puncture techniques right now, counter puncture technique and anterior puncture technique. Anterior puncture technique, okay, as usual, I think, or counter puncture, it uses 20 gauge Teflon coated needle that we will demonstrate right now. So anterior puncture technique, I think, is the commonest worldwide, but I heard from Dr. Samir Panchouli that in States, or he himself is using the counter puncture in vast majority of his situations. So palpate the artery as we said as we showed right now, introduce the needle to the point of maximum intensity until the pulsatile blood is coming. Please, once your blood comes, try to fix the needle by your left hand. I see many of my colleagues, they after getting blood, they leave the needle itself and start to insert the wire. Usually, any movement of the needle, I think it will change, and the room is very, very narrow, as you are aware. Advance the guide wire, withdraw the needle, and that we will see right now from this model. I think it is better to see
getting the radial puncture.
From the video.
One of them is the anterior Seldinger technique, and the other one is counter technique. After giving local anesthesia, one of the most important tricks to get the radial artery is to palpate the radial styloid. And the commonest mistake is to get the radial artery at the level of styloid process. It is at least 1 to 2 centimeters from the styloid process. Now we'll try to get the radial artery from the first puncture. Bismillah ar-Rahman ar-Rahim. This is approximately 60-year-old morbidly obese patient. This is a needle approximately 30 degrees from the artery. Try to feel the radial artery proximally, but don't press firmly. Otherwise, you will cease flow.
So while you are palpating the artery, don't press firmly, because any pressure in this proximal segment, you will reduce the flow. So this is.
And you cannot get the artery. After proper palpation, go to the point of maximum intensity at approximately 30 degrees from the artery. Bismillah ar-Rahman ar-Rahim. Exactly as we got it from the first puncture. Nice flow.
So just look for this flow is enough. Okay, usually the blood pressure is approximately 110, 120. So dribbling or just a continuous backflow, it is enough. Okay, and we will
keep flow a little bit for 1 second or 2 seconds, and just try to introduce your wire slowly, and without any resistance. I feel some resistance, okay, or gritty sensation, okay, because of the spasm.
So once you have a resistance, please don't push more. Okay, sometimes the local spasm happens in this area, and just with minimal pressure. Okay,
there is a spasm.
Stop.
Okay.
If you have a spasm, stop.
Okay, which is expected. The patient is markedly anxious. Okay, that's it. Okay, so in this situation, I think we have to get the full set out. Don't push.
So this, I failed to advance my wire, not because of the puncture, but I think because of anticipated spasm. I anticipate some problem happens here. Okay, in actual fact, it was just a few millimeters, so I didn't reach the typical site of the radial loop. So I did expect it was a spasm that happened that prevented
getting the.
Okay, so tips: never push against the resistance, and once the needle is plugged, please remove it. Okay, because it's very small.
We got it from first time. However,
okay, I injected intradermal subcutaneous nitroglycerin and just watch.
Found resistance due to spasm, so I gave intradermal 500 mics of Tri-D, and this second attempt after giving transcutaneous or subcutaneous Tri-D. In second attempt, I would like to go a little bit more proximal as compared to the previous one, because sometimes we have focal spasm that can improve, okay, after intradermal or subcutaneous Tri-D. Bismillah ar-Rahman ar-Rahim. 30 degrees also. Second puncture. Okay, got it. Okay. No.
Please look again for my hand. Okay, just once I punctured by my right hand. Okay, just look for what I will do by my left hand.
Intradermal or subcutaneous Tri-D. Bismillah ar-Rahman ar-Rahim. 30 degrees also. Second puncture.
While I'm fixing the needle by my right hand, I got it by my left hand to fix it. Fix it without any movement. If the needle moved, I think it will change its direction, and I think maybe in subintimate.
Got it.
You will get the.
Okay, nice flow.
You will lose.
Support wire, Walid. Support wire. Okay, go. Little bit. Bismillah ar-Rahman ar-Rahim. I think it is a nice trick.
While we are advancing the wire, try to corkscrew just to avoid entrapment of the wire in the muscular branches.
Okay, the wire goes smoothly right now. It goes smoothly, and this transcutaneous Tri-D worked very well. Okay, so after that we'll insert the sheath. This is a merit sheath. It's a nice sheath. Cutting doesn't require snip. Bismillah ar-Rahman ar-Rahim. Slowly, go. Okay, that's okay. Okay, give me a piece of gauze, please, with soaked with water, with saline. Okay, and put it here. This saline acts as a lubricant. Okay, so the wire can go very well. لو سمحت ست الكل خدي نفس عميق. Try to roll. Okay, twist little bit. Okay, 45 degrees, until the sheath goes completely. After that, take the dilator and the wire, both of them as a one unit. Okay, and now sheath has been inserted.
Okay. Why the patient, why I failed to advance the wire, I think it was very clear that I have a spasm, okay, just proximal after origin, from the origin till the mid segment of the radial artery. And I think we have to report that once you cross and when you insert your sheath, please document what was the problem. So never push against resistance, please. Once the needle is plugged, please remove it. It's very small. Okay, flush it and just shake it just to remove any issues inside it. Intradermal nitroglycerin works in very well in vast majority of situations, and soak with normal saline while you are inserting the sheath. It acts as a lubricant. So compared to the counter puncture technique, so what are the differences? Palpate the artery also. Introduce the needle to the point of maximum intensity until pulsatile blood is observed. Here we cannot insert the sheath, but we have to advance the needle and the cannula until blood flow ceases. So now we are transfixing the posterior wall of the artery. Withdraw the needle and the cannula as usual, okay, as usual without anything. So this is the only difference.
بسم الله الرحمن الرحيم. النهارده هنعمل ديمو ازاي نستخدم الكانيولا او النيدل راديال شيث اللي بنستخدم فيها ترانسفيكسيشن علشان نجيب الراديال ارتري بانكشر.
والموضوع counter puncture technique using the
سهل وبسيط. في الاول بنمشي نفس الستبس بتاعتنا من 1 مللي او 1 سم من الستايلود بروسيس، ونشوف الراديال ارتري نحسه كويس، وندخل على دايركت بانكشر على الراديال ارتري. نجرب كده. بسم الله الرحمن الرحيم. ماشي، ادي النيدل، انا هدخل اولموست 30 ديجريز لحد ما يجي لي بلاد فلو من الراديال ارتري. جالي blood flow.
So now I got flow. I think it will be a mistake to take the needle out. Okay, but you have to transfix the artery.
كويس اهو. دلوقتي هل اشيل النيدل؟ الاجابه لا. هدخل جوه بس ما المسش البريوستيوم.
Don't touch the periosteum to avoid pain and the periosteum.
ادخل لحد ما البلاد فلو يقف. اطلع النيدل بتاعتي.
Take the needle out.
ماشي، وبعد كده هشيل او هشد لبره، اسحب النيدل الكانيولا موجوده معايا بره، والواير بتاعي جاهز. خلينا عادي خالص. انا جاي لي بلاد فلو كويس اهو دلوقتي من النيك عادي خالص. بسم الله الرحمن الرحيم. الواير بسم الله الرحمن الرحيم. شاشه ناشفه احطها تحت الكانيولا. تمام. اسحب الكانيولا بالراحه خالص لحد ما يجي لي بلاد فلو. بسم الله الرحمن الرحيم. ادي البلاد فلو، نايس بلاد فلو موجود معايا اهو دلوقتي. هدخل بالواير. هدخل بالواير. بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. الواير داخل سموث خالص. الواير داخل سموث. الواير داخل سموث. انا دخلت كده دلوقتي بالواير. هشيل النيدل عادي خالص بالكانيولا. لحد دلوقتي ما اعتقدش ان في ستادي هيد تو هيد اوبن. الستادي اللي احنا هنبدا في علامه حاجه سعيد؟ نعم. الرحمن الرحيم. معلش.
So just, I think it's just, I will repeat it. I think it was a demo. So the same, I palpated the artery, introduced the needle and the Teflon cannula, okay, until blood comes, okay, back. So don't insert the wire in this situation, but I think you have to pierce the artery, transfixing it by both needle and the cannula. So take the needle out, okay, until blood comes, and insert the wire.
We have two ways or two techniques to get the radial artery. We have two types of puncture needles. One of them is anterior approach, and what we have right now is the cannula or counter. Like after that, I will withdraw the radial artery, and I will get across it, transfixing the artery. After that, I will withdraw the needle, and I will introduce the sheath. The way is exactly like the anterior approach, the stylo radial approach. The artery from the first puncture. بسم الله الرحمن الرحيم. دلوقتي في flow جاي لي خلاص from the first puncture. The mistake, if I will withdraw the needle, I think it will be a mistake. But the most important issue is to get across the artery. Try to don't touch the periosteum. Try to don't touch the periosteum. I didn't touch the periosteum. Okay, until the blood ceases from the needle itself. Get the needle out. هذه الشاشة ناشفة. Okay. Be ready with the wire. Try to withdraw the cannula slowly. Cannula slowly. بسم الله الرحمن الرحيم.
While we are withdrawing the cannula, just try to bring it a little bit as in touch with the skin. In this way, it will be coaxial with the radial artery.
Try to do, okay, until proper flush comes like this. Okay, we see the flush. You see the gush of the blood. Okay, introduce the wire slowly. Bismillah ar-Rahman ar-Rahim. slowly, slowly. Okay, the wire goes without any resistance, or the wire goes without any no resistance. Okay, that's enough, more than enough. Okay, after that, take the cannula out.
And
very helpful
as usual.
itself.
Okay.
Otherwise, this one is
so flattening of the Teflon cannula during withdrawal makes it coaxial with the radial artery. And the radial access technique evaluation rate done by Dr. Samir Pancholi didn't show any major difference or awareness that we may think about the arteriovenous fistula or hematoma or whatever. So there was no difference between both regarding hematoma or even radial artery occlusion as anyone may think. Okay, so here proper sedation is very, very important. A single stick as much as you can. And 1 or 2 centimeters from the radial styloid spasmodic cocktail is very, very important as mentioned right now. So now I would like to summarize why sometimes we fail to get flow or to advance the wire. Usually you may be away from the artery. This comes by the lack of experience, or you are catching on the arterial intima. Also, it comes by lack of experience. Usually with more experience, I think you will get more. So in such a situation, what you do, remove the needle and position it. And if you have a available ultrasound at your cath lab, so please, it will be a nice friend. Make sure that using the flexible tip of the guide wire, some nurses who are inexperienced, you may give you the wire and the hard one. Okay, once resistance, please don't push. If you got flow in the needle, then disappeared, remove and wash and don't relocate while you are still inside. It is not, doesn't, as I said, it is different from the femoral artery, which is approximately 9-10 millimeter. We are working in a very, very narrow room. The needle also is very small. Any small piece of fat, I think it will close it. Okay, so why sometimes we don't get flow or cannot advance the wire? Because of the radial artery occlusion. Just look for this patient, 47 male hypertensive patient who presented with anterior segment elevation myocardial infarction. I was in call. So I asked my junior to start the procedure. And when I finished, I went to the cath lab and I found him also almost, he did the diagnostic coronary angiography. So I was behind him. I didn't scrub. I let him complete the procedure. And 1 week later, the patient came in the same time with agonizing pain, agonizing hand, agonizing forearm pain. I examined the patient and I found feeble pulse. While examining the patient, okay, I found, unfortunately, the puncture site was in this segment, in this area, almost very close to the styloid process. So because of intense pain, I asked the patient to do a CT scan of his hand. And we found this is the radial artery, which is occluded almost from the styloid process here until almost the middle third. So I asked my junior and I asked him, please come. What is this? Okay, and he doesn't know the patient. He said, okay, it is a radial artery occlusion. Who is the donkey who did this case? So I smiled. It was a yellow smile, large smile. I told him, you did this and you punctured here in the styloid process. So please don't do and don't behave like my junior. Okay, so the puncture site should be 1 centimeter to 2 centimeters away from styloid process. And by the way, the CT scan identified high takeoff radial artery, which is also vulnerable for spasm that may result in radial artery occlusion. Sometimes we cannot get flow because of the ramification and the small terminal branches of the artery, like this patient that I presented. My patient presented 3 times, I failed. So ipsilateral ulnar artery identified 3 very, very small. Sometimes, or not sometimes, no, I think, okay, we cannot get flow, okay, or advance the wire because of the commonest cause that you have to expect, which is the radial artery spasm. How to prevent radial artery spasm? How to anticipate radial artery spasm? How to treat radial artery spasm? It will be a very interesting session, inshallah, next week regarding radial artery spasm, coronary artery spasm, and their relationship. Waiting you, inshallah, and very happy to listen to you.
Very interesting, Mansoor. Very demonstrative talk. Thanks very much for the effort you are doing, Mansoor.
Thank you so much.
Hatem, would you like to ask Mansoor anything?
That was a very systematic and a demonstrative talk and very informative, Professor Mansour. I have no comments. It was a very comprehensive overview.
Actually, I enjoyed both your talk and the very nice demonstration of Mansour. Next week, we will be talking about the problem of radial artery spasm, how to predict, how to avoid, and how to treat. And at the same time, we will discuss coronary artery spasm and what is the practical points of coronary artery spasm. It was a very nice day. Thank you very much, all the participants, and we will hear the last comment from Hatem and Mansour.
Hatem, please.
I would like to start by thanking Prof. Mansour and Prof. Sameh for their encouragement and for allowing me to participate in the course. I have actually learned tons from the sessions that I've attended. And I'm sure everybody else in the audience at various levels of experience have also learned a lot. And we always look forward to the next session. Congratulations on this magnificent course.
Thank you. Mansour?
Almost always happy to see Dr. Hatem and to listen to his nice, systematic, highly informative talks. So thank you so much, Dr. Hatem, if this course is successful. So I think you have actively participated and led to the success of this course. I wish also the attendees to be happy or to get information and for their application of the course as well. And to start their radial program, I wish this information that we provided today and previous days, practical and clinical to apply. And I would like to thank also my Prof. Dr. Sameh for his leadership for this course. So I think we are awaiting you, inshallah, next session for Spasm Day, radial and coronary.
Okay, Mansour. Thank you all, and looking forward to seeing you next week, inshallah. Thank you. Good night.
Assalamu alaikum.
Assalamu alaikum.
See you.